Okay, we are up over the 100 attendee mark, so that's a sign for us to get going. Thank you very much, everybody, for joining us this afternoon. And I'd like to open this AMA update on the COVID-19 vaccine rollout. Just to start with, I'd like to acknowledge the traditional owners of the lands on which we are all meeting today, to pay our respects to their elders past and present, and to acknowledge any Aboriginal or Torres Strait Islander people who may be on the call today. I'm the National President of the AMA. We're joined also today by Chris Moy, my Vice President, also President of South Australia, who has been our lead GP, I guess, advising government and driving our vaccine advocacy within the AMA. I'd like to welcome you, our members, to the panel, and also our invited speakers, who I'll introduce in a moment. The purpose of today's webinar is to, I guess, add some extra information over the recent webinar that we did a few weeks ago, to update you on the rollout of the vaccine, the constantly changing plans, and to give you the opportunity again to ask questions of the experts that we have in front of you. But we'd also like to delve into some of the science, the emerging clinical guidelines and questions that we know that GPs in particular, but also many others in the medical profession, will be having around the indications, any contraindications, and the many questions that we're all expecting to hear from our patients over the coming weeks as this rollout continues. It's certainly very exciting to be at this point where we are at the moment, having negotiated this crisis for the last year, having hoped that vaccines would come early, and really being, I think, incredibly lucky that we have two highly effective vaccines that are currently available. I've actually just booked my appointment for my own at my local hospital early next week, so really excited about that. But also recognising the challenge ahead of us to get our whole population vaccinated, and wanting to minimise any difficulties along the way. But that's really why we're here today. So we have some fantastic experts here for you to ask questions of today. And the first is our Deputy Commonwealth Chief Medical Officer, Professor Michael Kidd, and also our, one of the first Assistant Secretaries at the Department of Health, Dr. Lucas de Toca. They are overseeing the vaccine rollout on behalf of the Commonwealth, and are here to make some comments and also answer your questions around the rollout. Our second speaker that I'd like to welcome is Dr. Charlotte Slade. She is an immunologist and Director of the Department of Clinical Immunology at Royal Melbourne Hospital. She has a PhD from the Walter and Eliza Hall Institute, and is here to really provide that real expertise to some of the immunological questions, some of the concerns that I know you're going to have around the safety of the vaccines, and also their effectiveness in some of our higher risk patients. So we'll hear from Michael and Lucas for around 20 minutes, Charlotte for about 10 minutes, and then Chris and Moy will make some comments on behalf of the AMA for a few minutes. And then we'll be open to some questions from the audience. So please open the chat box, pop your questions in there. We also have some prepared questions which have been sent in prior to today's webinar. Some of them may be answered in the talks, but if they're not, I will do my best to put them to the panel as we go through. We're going to finish at 1 o'clock exactly, at 1 o'clock, my time anyway. That's 4 o'clock your time for those of you in the East. And hopefully, if there are still any further questions, we'll be able to forward them to the panelists as well. So without further ado, I would like to introduce Michael Kidd and Lucas de Toca.
Thank you, Omar, and thank you once again to the AMA for inviting us to take part in this webinar with the members. Thank you for the great support that the AMA is providing to the Commonwealth in the development and the rollout of this vaccine program, the largest mass immunisation program we've seen in the country's history. And thank you to everybody who's online for your active engagement in this rollout as we move ahead. I'm going to provide a bit of an update on where we're up to with the vaccine rollout, and then throw to Lucas to talk about the specifics of the rollout that's happening through general practice. So as you know, the vaccine rollout's been happening over the last 10 days or so, started Monday last week. Already well over 70,000 people have received their first dose of the Pfizer COVID-19 vaccine. That includes over 20,000 people in residential aged care facilities and disability care facilities right across the country. And those programs to roll out to phase 1A continue to scale up. And with more and more teams going out to aged care facilities over the next couple of weeks. And of course, the state and territory hubs who initially have been vaccinating mainly the quarantine workers and the border force workers, and now moving through vaccinating healthcare workers in phase 1A. Phase 1B, we're expecting, is going to start rolling out probably towards the end of this month. And that will include all the rest of our healthcare workforce. So, and not just doctors and nurses, but everybody working in healthcare. It includes our on-site administrative staff in our healthcare settings, cleaners and kitchen staff and other ancillary staff working in hospitals and other facilities. The workforce supporting medical practitioners in clinical settings, including, very importantly, our students, our clinical students, medical students and others who are working alongside us. And we'll also include healthcare workers who are providing in-home care to people in their own homes. So very widespread coverage in phase 1B. The phase 1B also, of course, includes all of our population aged 70 and above, our Aboriginal and Torres Strait Islander population aged 55 and above, a number of emergency workers and other critical people in other critical industries, and then a very large group of people with underlying medical conditions or disability, which, if they were to contract COVID-19, would put them at increased risk of developing more serious complications. That list of the underlying medical conditions has been developed by ATAGI. It is on the Commonwealth's website. We can go through individual conditions if you wish, but it includes people with serious chronic illness, people with diabetes, with serious heart disease, with serious lung disease, and many people who have had a diagnosis of cancer. The criteria, of course, are continuing to be looked at over time. Omar did mention that things are changing. There's reasons why things are changing. It's because the evidence continues to evolve as we learn more and more, particularly with people being vaccinated around the world. We've now had over 200 million people who've received their first dose of one of the COVID-19 vaccines around the world. And of course, the supply of vaccine is influencing what's happening as we roll through. We've had a couple of shipments of Pfizer vaccine arrive in Australia. We've had one shipment from overseas of the Astrazeneca vaccine. As you're probably aware, we've had a blockage of the second shipment of Astrazeneca coming from the European Union. The good news, though, of course, being that we will be rolling out our onshore production of the Astrazeneca vaccine over the next few weeks. And by the end of the month, we're anticipating that CSL will be rolling out 1 million doses of the Astrazeneca vaccine every week, which will allow us to rapidly scale up the rollout of the vaccines. So that's the update I wanted to provide. Omar, happy obviously to answer questions as they come through, but I'm going to hand over to Lucas now with the exciting news about the rollout through general practice.
Thank you, Michael. Thank you, Omar and colleagues from the AMA for having us today. Based in Ngunnawal country, Ngunnawal Daura, so I want to acknowledge that. I also wanted to start by thanking Chris and other colleagues in the AMA and the colleges for being passionate advocates of evidence and also the voice of doctors working with government when we designed this program. I think one of the things, as it's going to be the thread, I think, from Omar's intro, and then Michael picked up, which is the uncertainty and the change in advice, which is something that doctors in general, GPs in particular, are very familiar with dealing with day to day, and has been exacerbated over the last year with the ever-changing advice, recommendations, information, and thinking on our feet and acting on our feet as we've been dealing with the different phases of the pandemic. Now, the exciting phase of the vaccine. So I wanted to thank everyone for their endurance through this very it's a cliche, but these very trying times where we're all very tired. Department, doctors, advocacy bodies, colleges, everyone, our patients, everyone is very tired. But we're still pushing through with this new stage, and I think that needs to be recognised. So I wanted, thank you. And Chris is in every committee I've been to, so he's a trooper. Thank you. Exciting times, trying times as well. We are, as we speak, and I think most people will have got it already, through the PHNs, we've been issuing 4,764 letters to all eligible general practices that put their hand up and confirm their eligibility as part of the rollout in primary care. Taking a step back, so the government is committed to, and the minister made very clear that primary care would be a cornerstone of the vaccine rollout. There's full recognition that general practices provide the immense majority of immunisations in Australia, and it's hard to find a part of the system that is better suited to support and take centre stage in this rollout. So, as you will know, we worked to put together an approach that would allow different parts of the primary care system to work together to offer access to the vaccine in a manner that is safe, effective, and free to everyone, particularly those parts of the population, especially in phase 1B, that are more vulnerable, like older people or people with underlying conditions that are also more likely to have an existing relationship with a GP. So we went out with a GP EOI, and I'm sure we'll have a lot of comments on that. And we had an overwhelming response with over 5,000 practices out of there, just over 6,000 accredited practices putting their hand up to join the rollout. We also had a lot of hands up from unaccredited practices, and I think we need to absolutely recognise that unaccredited practices that might be unaccredited for a whole range of reasons are also routinely delivering vaccinations and doing so very capably. So it wasn't they're putting the sort of the limits or the context for the rollout in this phase, in that initial EOI to accredited practices, wasn't a reflection on or a quality judgment on unaccredited ones. Was simply a way to have an external quality assurance process through the RSCGP accreditation process that would, especially for that early stage of the rollout, give comfort there was a standard, an external standard applied to when we don't really have the logistical capacity to individually assess and do site visit for each of the practices. So there was a choice based on having that external assurance element, noting that it includes a vast majority of general practices in the country. And out of those accredited practices, the majority applied to the EOI. And of course, unsurprisingly, the vast majority, over 90% of those that applied for the EOI were also found to be eligible. Eligibility being self-assessing as meeting the site requirements and being an accredited practice. The idea is that the primary care network, which covers all parts of the country, will be able to deliver the vaccine from the beginning of this phase 1B, where people with particular high risk are eligible to apply to receive the vaccinations, and we needed to bring as many general practices as possible from the beginning. We had a lot of feedback from practitioners on the ground, from patient groups, from the AMA and others, that making a small number of practices or limiting the rollout through a small number of practices would actually limit the capacity of patients, or the possibility, the likelihood of patients to access their own doctor, and that we, if we were going to go to primary care, it made more sense to essentially play to primary care's strength and do a rollout that looked as close as possible to how comprehensive primary care services deliver vaccines, as opposed to asking GPs to stop being GPs and become mass vaccination centres. So based on that feedback and the incredible response to the EOI, we made a commitment to ensure that as many practices as possible are rolled out as quickly as possible, so that every eligible practice is able to offer the vaccine from very early stages of the rollout, so that it's closer to the people who need to access it, and a majority of people would have the option of accessing the vaccine from their own GP. Complementing this system, we also have the role of the GP respiratory clinics that were established nearly a year ago. I think the first one opened on the 21st of March last year. So here we go. And have been providing access to assessment and testing services in that GP-led model to people presenting with COVID symptoms, and have become quite a staple of the current Australian COVID pandemic tapestry. Using the existing network of GP respiratory clinics to be able to offer that some certainty, because we have an existing contractual relationship with those clinics, and they're set up in a way that could provide access to vaccination services in addition to general practices. GP respiratory clinics also offer us a platform that could specifically cater for people without a Medicare card, because they have that existing contractual relationship with the Commonwealth means they can bill us directly, and it's not a Medicare, it's equivalent to Medicare, but not a Medicare dependent model that might be a barrier for access to people without a Medicare card. Who are also eligible to receive the vaccine for free. Another element of the primary care rollout are, of course, the Aboriginal Community Control Health Services, and we've been working with NACCHO and the state and territory big bodies for Aboriginal health to develop the approach to ACHO, so that now over 100 ACHOs have confirmed participation on the rollout, and will also commence from those early stages. And NACCHO and the Aboriginal big bodies are supporting their members in making sure that they have the support needed to deliver the vaccine from early stages. Phase 1B and the rollout in primary care will start from late March, that week of the 22nd of March. And the idea is that we will do a staggered approach, so that there can be good management of the logistics and distribution, and we can provide certainty to the practices and make sure that they know what doses they're getting and they can plan. And we'll start with about 1,200 practices on that first week, adding then sequentially weeks after, so that by week 4, all 4,700 practices that are eligible and want to start will be able to deliver the vaccine. All over 130 GP respiratory clinics and the over 100 ACHOs will be able to offer, which will give a good coverage of the entire country across different settings. Of course, going to a large number of points of contact and locations means that because we don't have unlimited dose availability, choices needed to be made in terms of allocation to each of the practices. And I'm sure we will get a fair bit of feedback on the individual allocations that have been offered to different practices. We needed to be able to model how that looks and what to do with those doses. So we applied a combination of factors to achieve something that was equitable across practices, but also equitable across geographies. So we base our initial thinking into the allocation on what practices had self-estimated in the EOI. We would never ask a practice to deliver more than they self-assess they could do. We also looked at triangulating that with the standard whole patient equivalent, the SWAPI, that is a proxy for your regular patient population as part of their practice incentive payment program, which was a way of assessing that self-estimated capacity versus what the population that is serviced by that practice. And then we looked at geographic coverage, so looking at how the clinics are distributed across the country, and density of distribution of the 1B specific population, so people over 70, Aboriginal Torres Strait Islander people over 55, people with underlying conditions as described by Michael. And then based on that, we've been offering 50, 100 or 400 doses a week to practices across the country, with the high throughput ones starting in week 1 and then completing throughout the next 4 weeks. We know that is lower than the capacity that a lot of the practices are able to deliver, but that also enables that everyone who got that eligibility and could put their hand up to continue will be able to deliver the vaccine. And there will be, by the time we finish the rollout on week 4, over 5,000 points of contact across all levels of geography across all rurality and remoteness to be able to provide access to the vaccine. That will be complemented with state and territory clinics that are being finalized now to fill gaps wherever there's no general practice availability, or ACHOs or GP respiratory clinics, and other parts of the system working together to ensure coverage across all elements. This is not a static model. This allocation, we needed to provide certainty to the practice so that they can plan ahead and start thinking of how they're going to organize their bookings. So we wanted to communicate to all applicants at the same time, and that's why the letters are going to everyone, not just the practices that start in the first week, but the practices that go to all 4 weeks, and they all have received an onboarding pack that we are hoping will answer a lot of the questions that practices had. And again, I have to thank Chris and Nick and other colleagues from the AMA for providing input into these documents, and often with like getting them at 11 p.m. one night and asking to get it back to us by 9 a.m. the following morning. So thank you. And hopefully we'll answer a lot of those questions in terms of stock and logistics and management, including dimensions of the boxes so that you know how to manage storage in your fridge, etc. The model is not static. So as I said, we needed to provide certainty for the first few weeks of the rollout. So practices know at least what minimum they will get and the guarantee of supply based on that domestic production capability. But as the model evolves, we potentially secure more doses, or even with existing doses, the dynamics of supply and demand and how practices are using their stock might actually free up some doses in the system, and then practices may be offered at later stages higher allocations or higher maximum allocations that they can order through. Of course, we will never ask a practice to, or practice will not be forced in any way to accept higher allocations that they're comfortable with, but we might raise the cap so they can order higher allocations. With that onboarding pack, we also confirm that automatically, based on the doses that they're getting, practice will also be supplied with their syringes, needles, and sharp disposal bins required to conduct their operations. That's probably as much as I should say up front, not to get in trouble with Omar with the time. And I'm sure there's heaps of questions that we can get to.
Thank you very much, Lucas. I think you're getting a sense of just how massive the logistics are by Lucas's talk there. There's an awful lot of moving parts here as you do such a massive rollout. But the AMA is certainly very happy that the message has been heard by government, that general practice is ready to step up here, that GPs want to vaccinate their own patients, and the most logical place for GP to start was 1B. So, really pleased to see that, and hoping too for some flexibility for those practices that are able to step up and basically provide almost a mass vaccination clinic, that there may be the ability to do that down the track as we get vaccine availability. So thank you very much, Michael and Lucas. I'll now hand over to Charlotte, who's going to have a chat to us about some of the immunology areas, some of the medical areas. There are some inevitable questions, and hopefully Charlotte will be able to cover those and also answer questions later. Thank you.
Thanks, Omar. Thank you, Michael and Lucas, for all your hard work. So I'm an allergy immunologist specialist at Royal Melbourne Hospital, and I'm very excited, obviously, about the opportunity to talk to you all about the 2 vaccines that we will have available. We do have available now, the mRNA vaccine from Pfizer and the Astrazeneca vaccine, which is a viral vector vaccine. So importantly, these vaccines are both not live, so they're safe to be given to any individual on immunosuppression, anybody who is immunodeficient. I suppose most of the questions have been surrounding the risk of allergy. There has been some concern with the mRNA vaccine from Pfizer that there may be a slightly higher rate of allergic reaction to this vaccine than there is to other vaccines, but it's still an extremely low rate of anaphylaxis or other hypersensitivity reactions. So at the moment, our guidelines, the ASCIA guidelines, so the Australasian Society for Clinical Immunology and Allergy, recommends that all patients who are immunosuppressed or have other comorbidities that put them at risk of severe disease should be vaccinated, and it's safe to vaccinate them. It's also safe to give these vaccines to patients who've had previous allergic disease. even if a patient has had anaphylaxis to a food or other medication, we recommend vaccination. The main consideration then is how long to observe them after the vaccine. And our current practice is to observe for 30 minutes in anybody who's had previous anaphylaxis. The only real concern with regards to patients who have allergic reactions are those who've had reactions to multiple medications or multiple vaccines previously. And in that situation, I would recommend discussion or referral to an allergy service for further consideration of specific allergic testing. The other consideration with those patients is that they may have a mast cell disorder. These are very rare conditions which put people at a higher risk of having a systemic allergic reaction to medications, foods, and vaccines. But again, these patients will be very few and far between. So generally, we are considering that it's an extremely safe vaccine. Immunosuppression shouldn't stop patients from receiving it, and in fact should make them more eligible for the vaccine. And if people do have concerns, it's certainly worth discussing with them, but it's essentially a risk-benefit analysis. What is the likelihood of the patient being exposed to COVID? What is the likelihood of them developing severe disease? And in that situation, it's weighing the risk and benefit, but essentially these vaccines are very, very safe. That was very quick. Would you like me specifically to go through any other advice or immunological points on the vaccines? So the mRNA vaccine is the Pfizer vaccine. mRNA vaccines are fairly new, but the technology has been around for quite some time. mRNA vaccines don't have the adjuvants that other vaccines traditionally have had, but mRNA can stimulate the immune system directly. And this may cause some of the non-allergic symptoms, so fever, pain, and general malaise occasionally after the vaccine. One of the excipients in the mRNA vaccine is polyethylene glycol, and this is the agent that may be the culprit if a person has had an anaphylactic reaction to a dose of the COVID-19 vaccine, the mRNA. Polyethylene glycol is found in a number of medications and a number of other vaccines. So if patients have safely had vaccines but had one reaction to a vaccine, for example, but subsequently tolerated a number of vaccines, they would generally be considered safe and tolerant of polyethylene glycol. It's also found in a number of other bathroom products, bowel preparation products. So unless you have a patient who is reacting to a lot of different medications or vaccines, then it's very unlikely that they're allergic to this component of the vaccine. And essentially, the mRNA vaccine has no other components that would be likely to trigger an allergic reaction. The Astrazeneca vaccine appears to have a lower rate of hypersensitivity reactions, and I don't think that the concern is as great there. Although having said that, polyethylene glycol is also contained in the Astrazeneca vaccine. Most patients just need to be observed for 15 minutes after the vaccine, but if they, as I said previously, if they have had a systemic reaction previously, we observe them for half an hour. And I would refer you all, you're probably all very familiar with the ASCIA anaphylaxis and allergic reaction action plans, but they're also available on the ASCIA website. So if you do have concerns about how to manage a reaction, I would direct you there.
Okay, thank you very much, Charlotte. There's heaps of questions coming in, a lot of which are for you. But before we go to the questions, I'll hand over to Chris Moy, who'd like to speak to you all briefly on some of the AMA issues. Thanks, Chris.
Yeah, just a few things have come up along the way, so I'll deal with some of them. So again, thanks for your hard work, Omar. You've really kept particularly general practice involved in this. And I'd like to also say that it's been great to have Michael there, because Michael, being a general practitioner, he's been a great advocate for general practice in this. And I think everybody's starting to understand the value of actually the trust of general practitioners involved in this as time goes on, really, and spreading the load as well. But the trust of general practitioners with our patients is going to be really important in this rollout. Look, we've been very involved in the advocacy side of things on a whole number of practical issues, the education module to try and streamline that down, to get as many practices involved as possible, and to make sure that we get the consumables with them, the billing issues, the co-billing issues, making sure that nurses can do it for us. And also we continue to work with the government department about making sure that those who didn't pass the initial EOIs or are unaccredited can get involved at some stage, and we will continue to advocate for that. So watch the space, I think. Look, the model, as Lucas has indicated, has become that it's really much more of everybody that was approved is on board. I know some of the people who have got their packs already were a little bit disappointed about the few numbers that they've got, like they're getting numbers about 50 or 100 shots in the first round. Look, I think one thing to keep in mind is this is not like the flu vax where we have 15 million shots ready to go. These are going to come online and they'll build up over time. And in many ways, the whole reason why there is so few is because we're making it's equitable, and it's also so that we can actually get people to get used to this, fit it in with normal sort of practice, and potentially fit it in with more opportunistic vaccination. And also it'd be a bit like trainer wheels in the initial stage, and hopefully as time goes on we get more used to it and build up. So I don't think it's necessarily a bad thing, but I do understand some level of disappointment, because I think people were potentially imagining that they'd get, you know, thousands in the first week, and they were saddled up to do that. Look, there has been a couple of concerns over the week about the advertising side of things. There was some stuff put out by the TGA which got a few people confused over the last week. Look, it's really important. This was all about advertising and promotion, not about, there was stuff on social media about, you know, I'm not allowed to talk to my grandmother about the COVID vaccine and which one I give them. That is complete rubbish, okay? It's about advertising and promotion. And the reason why is to make sure that the information about it is consistent. It's a government vaccine. It's been paid for by the government, that the information is consistent. There's trust in it. We're not over-promising. We're not imbuing it with powers that it doesn't have. And we're not putting things like, oh, come on in and we've got the better vaccine here, and come on in and we'll give you a jam donut at the same time, because that's really, to be honest, we'll leave that for pharmacists. Can I say that, Michael? But we're not allowed to, I know they're not allowed to do that, but you just can't do that. And that's actually consistent with normal advertising guidelines. So you can talk to your patients about it. And if they ask you which vaccine you have, you can tell them, because it may be relevant. For example, if they've got a history of anaphylaxis, as Charlotte has indicated, they may be better maybe with the Astrazeneca in certain situations. Just about explaining the vaccines, we're getting tons of questions about, you know, what the vaccine does. And I've got to say, I mean, we're hearing a lot of stuff out there. I'm applying the KISS principle. The whole thing, the only thing that we know the vaccine definitely does is protect us from severe disease, ending up in hospital and dying. Okay, this whole stuff about herd immunity and community transmission is just way out there at the moment, and it's really beyond. I'm too dumb for that at the moment, and it's still emerging data. Obviously, we'd like to get to that point, but that is a secondary aim. I've actually put on the you can see there's suggested links. There's some stuff about how to explain it to your patients, some new, very good data about real world data, not this efficacy stuff, real world data from Scotland and also the Public Health England about the one shot, not only protecting people within about a month from severe disease in every age group, but also those over 80. Pfizer and AstraZeneca pretty much equivalent at about 3 to 4 weeks. They're basically 80% protected for the over 80s after one shot. However, there has been some concerns, I know, behind the scenes about the variants as well. There's a really interesting video on YouTube, watch from about 17 minutes, about the fact that there is some really exciting data that really, if we get the second dose in, that we really can protect against the variants as well. So some emerging stuff. And obviously these are preprints, but I think it may help reassure you about the information you give to your patients, particularly about those over the 65, where the TGA's put that little theoretical qualifier about talking to them about the risk benefits. But I think there's really no, from my mind, there's no sort of really clear, there's no reason not to give them at this stage, and the data is emerging. So please have a look at that. It may be of interest to you. Finally, I was just going to say is I do understand that it's still a bit scary for all of us going into this. This has not been one of those projects that has had years in the making, and this is the biggest project, and it's not. We're building it as we go along, and you know, the work with Michael and Lucas and RICGP has been, and other groups, has been really important and great, but it's been really scary to some degree because we are trying to cater for everybody. What I'd say to you is, I mean, we have had calls about people now sort of second guessing themselves about whether to continue. And then we've had calls like saying, well, look, make sure that, you know, we don't want to do it now, but we don't want to make sure the pharmacists don't do it. Well, I'm going to say, we can't do that. We can't have that situation. It's us or who is going to do it. And all I'd say to you is it really is time, if you can, just to have that, do the best we can with what we've got. We'll learn as we go along a little bit, really try and stick to the safety as being a critical aspect, understand our community, the government and our patients really need us at this moment in time. And hopefully we can get this done and really be a credit to the profession over the next few months. So, and we'll just keep on advocating for you, and just if you need us to, bring in all the information that you need to. So thank you.
Thank you very much, Chris. So we're going to go now to questions, and I'll try and group them, and I'll point them in the direction of one of our experts. And guys, if you could please keep the answers brief, we'll get through more questions. So I might start with some of the clinical stuff. So one set of questions are around the over 65s. With the sort of TGA advice that you know, there's some concern over efficacy, and also over whether it's appropriate for people at end of life. But there's been ATAGI guidelines recently published, so an update on that, and also around pregnant women. You know, we've seen official advice on that, but for GPs having to have that conversation with women who either are intending to become pregnant, who are pregnant, or who are breastfeeding, have all got different sets of questions. So might point that one initially to Charlotte, and then perhaps Michael or Lucas could give us the official line as well.
So with regards to pregnancy, that's a common question. People planning planning a pregnancy, the advice is still that the vaccine is safe. With regards to patients who are pregnant, because the studies haven't been performed in pregnant women, it's again a risk-benefit analysis. And essentially, if a patient is at high risk of being exposed to SARS-CoV-2 or at high risk of severe COVID-19, then generally it would be considered advisable to give the vaccine to that patient. With regards to breastfeeding, there's no contraindication to the vaccines. Oh, and the elderly population, sorry. I mean, it's my opinion. Yes, I acknowledge that the elderly may not have as robust an immune response to the vaccine, but if they're certainly at risk of severe COVID-19 infection if they do become infected. So I certainly would recommend the vaccine to the elderly population.
Michael, do you want to add something? And in particular, the which vaccine for the elderly question also comes up quite frequently.
Yes, so both vaccines are effective. Both vaccines are recommended for adults of all ages. The statement which came out initially from the Therapeutic Goods Administration was a highly precautionary statement based on the research evidence which have been presented through the results of the clinical trials. We've since had released further trials, and as Chris has mentioned, the real world experience about these vaccines saving lives in elderly people overseas. The main precaution in the elderly is for those people who are very frail and rapidly approaching the end of life, a discussion about whether it is appropriate to be vaccinating that person, which is the same for any vaccine in someone who is at that point in their life. But for everybody else, please vaccinate.
Thank you, Michael. There's been a few questions around the efficacy of the vaccines in people with various different levels of immune deficiency, including some of the syndromes, but also cancers, chemotherapy, etc. Is there, Charlotte, any preference or any data around which vaccine may be more appropriate in some of those people in whom we may expect a less efficient immune response?
There's not really any particularly difference between the mRNA vaccine and the viral vector vaccine with regards to recommendations for the immunosuppressed population. I guess logistically, I'm assuming that we will be giving the Astrazeneca vaccine to most of those people in Australia. And yes, as I said about the elderly population, they may not form as robust an immune response, but these are the people who we really need to be protecting against severe infection. So we think we're confident that it's safe in those people, and certainly we're interested in looking at the immune response in some of those groups of people, but there's certainly no reason why not to give them the vaccine.
Thank you. And while we've got you, there was a question early on about whether the mRNA hangs around after the vaccination, and could it cause an ongoing immune reaction if it continues to express the protein on the surface of the muscle cells?
It's my understanding that it wouldn't hang around for a prolonged period of time. It wouldn't continue to be translated after a certain point, and therefore it wouldn't generate that kind of a delayed immune response. It does trigger an immune response by signaling through toll-like receptors, which can cause some of those non-specific symptoms, but I don't think it's likely that it would cause a myositis in that way.
Thank you, Charlotte. We had a question around what training is required for GPs or others vaccinating in general practices. I would have thought that had been fairly heavily covered, but perhaps Lucas or Michael, you might be able to give us a very brief and succinct answer to that one.
Yep, sure. So every clinician involved in the vaccination with the COVID-19 vaccines as a part of the vaccination program, regardless of setting or profession, will have to have completed the mandatory online training that is currently available on the department's website, in addition, of course, to any other requirements relevant to their scope of practice and state and territory legislation that govern who is an authorised immuniser.
Thank you. There's been some questions around the second dose, particularly around AstraZeneca, and perhaps some ongoing confusion around obviously the two vaccines with two very different timings, and also with AstraZeneca, the trials had different timings to what we're actually implementing. But I might just summarise that by saying AstraZeneca is 12 weeks. That's the recommendation, but you can go earlier if there was some reason for that. Everyone's nodding. That's good. And there was a question around, what if a patient doesn't come back within the 3 months because they're working away or whatever? Is it a problem to vaccinate them with a longer duration than 3 months? Who's that one for? Charlotte?
Was that to me? Sorry, Omar. Sorry, could you just repeat that question for me?
Yeah, is it a problem if the duration, the gap between two of the AstraZeneca vaccines is longer than 3 months?
I don't see that would be a problem. I think the advice is that it's a minimum delay, but not. I don't think the duration should be a big issue.
Yep. And on the vaccine doses, we've seen pretty good results from a single dose of the vaccines in some countries around the world. But one of the videos that Chris has put up does cover the question of why you need a second one. Chris, do you want to give the punchline from that video to everybody as to why the second dose is still recommended for both of these vaccines, even though they're pretty good after one dose?
Yeah, so I mean, obviously there's a lot of data showing that even one dose really protects you against severe disease and hospitalization. But if you watch this video on YouTube from the Zoe COVID symptoms study, which talks about, I mean, there were some concerns about AstraZeneca not being as good against the South African strain, but it does appear that a lot of the issues are to do with T cells, and it's got to do with the making sure you get the second shot in. At the second shot, it makes a big difference. And so you think about the Pfizer, you get 2 shots in within 21 days. So the second shot on the AstraZeneca is at 12 weeks. That's why we're getting delayed data on it. So it's actually really important, that second shot. But watch that video. It really is extremely reassuring, and actually may make our life a lot easier. Actually I was actually very relieved watching that. But yeah, no. So the second shot is really important for the robust protection, particularly I think in the longer term against variants as well.
I'd just like to reiterate that, Chris, a durable immune response is one that is boosted after that second dose. So memory cells hang around, but they really only form well after that second dose.
Omar, if I may, I think it's related, and there was a follow-up question on that on second dose as well, but the non-clinical aspects of them. Practices do not have to set aside allocation of what they're receiving for the second dose. The government is setting aside a contingency to be able to have their second dose spaces available. Practices are encouraged to try to book both appointments simultaneously, or encourage people to book their second dose appointment as quickly as possible. And we are planning for the contingency that from week 12 onwards, there will be almost double doses circulating, so that second doses can occur and first doses can continue, which will enable us to have a combination of bringing more points of contact, more practices into the mix, increasing current throughput in the existing ones, so that and it will be a mix of both that we'll be working on and with our partners, including the AMA, moving forward, so that by the time that dose doubling happens, when the second dose contingency comes into circulation, there's enough supply in the system to cater both for those second dose appointments while continue to do new first doses.
Thank you. While I've got you, Lucas, we have a few questions around access to the vaccine, different sort of aspects of that. So there's questions around people living in care homes, how and when would they access the vaccine? What about people who can't really leave their home? Are we expecting any kind of outreach service that could go to the home of a 95-year-old living at home by themselves? There's questions around doctors who work in aged care facilities, how and when they would access the vaccine, and also which, and also their staff. How and when would they be vaccinated? So I'll bundle those all up for you in one go, Lucas.
Thank you, very kind. So in care home, people in care homes, they're eligible under category 1A, and there are a number of avenues in which this is happening, and the Commonwealth surge providers that have been doing the in-reach into residential aged care are also doing in-reach into disability care. It's ramping up as we go through, so we'll get more significant as the weeks go by. So that will be for disability and aged care home arrangements. For people who are homebound and are not in aged care homes, we think there will be a mix of different approaches. Another point for going to primary care is that primary care already delivers services to those patients. So if the regular GP does home visits, there would be options for doing that, noting that there are logistical considerations with home visits and the multi-dose vials in that. So there would have to be a fair bit of planning around that. But we think there's not going to be a one-size-fits-all anyway for those particular cases, and we will have options to look at what the general practices are doing, and whether that's reaching or areas where that is not happening, or people who don't have a regular doctor might need other approaches, like using the Commonwealth surge workforce options or other providers. For GPs who provide care in residential aged care facilities, that would be considered, if they do so routinely, they would be considered staff, so they would be eligible under 1A. At the moment, the vaccination of the aged care workforce is happening slower than the vaccination of the residents. We've prioritized within 1A, getting through the vaccination of residents as the most vulnerable for severe disease as a first priority. But we are ramping up the approaches for vaccinating workforce, which would include GPs, noting that we are talking about phase 1B commencing in just shy of 3 weeks, by which all healthcare workers, including everyone working in our GP practice and all the staff, not just the clinical one, will become eligible.
Thank you, Lucas. Next question is around some MBS issues. I'm not sure if it's for Michael or you. There's a question around the him. He's down on my screen too. The question around co-claiming items with usual attendance items. If a patient opportunistically brings up the vaccine, so you're saying them about their hypertension, and they say, by the way, can I have my vaccine? If you happen to have a slot available, can that be co-claimed? And the same person has asked, is there a limit to how many co-claims you might be able to do? And there was also a question around I presume around the PIP payment for the second vaccine. If someone has gone between 2 different practices, how is it justified that the PIP payment is not payable to the practice? So I'll leave those to you, Lucas.
Thanks. Michael always leaves me the fun ones. So on co-claiming, I recommend, and we can. I mean, I'm sure Chris has it and is very active in the chat, but we'll send a link to the online fact sheet from MBS Online that explains how the new items work, and it has a section on co-claiming that might clarify some of this. But broadly, co-claiming is permissible in the context that we've been discussing for unrelated services. So we don't want to emphasize too much the opportunistic service. Someone presents with something else and they're like, by the way, I'm eligible, I want to have the COVID vaccine, because we think that because of the multi-dose vial and the fact that when you open one vial, you need to use the doses within hours, it's better not to, it might limit the opportunity for opportunistic. However, from a claiming perspective, and if you organize your practice in a way in which you can maximize the use of that vial anyway, that would be an example of something that would be absolutely allowed. The co-claiming is permitted as per normal rules, and subject to the 80-20 rule, which the COVID items aren't, if the service that you're co-claiming is unrelated to the vaccine. So co-claiming is not permitted for vaccine-related services. We've had a number of questions about how that works in the context of a 10997 or other examples. But if the services are unrelated, both having the example that you mentioned of the opportunistic vaccination, but also the contrary. Someone comes with the vaccine, you haven't seen them in a year, they're a hard to reach patient, and they have an outstanding management plan or an outstanding 738 or our health check, and you have, it's somewhat urgent because it's overdue and you have concerns that you might not see them again, then you can refer them to our other part of the practice or yourself when you finish that service and co-claim the management plan or the health check or whatever it is appropriate as a separate service from the vaccination service. But co-claiming is not allowed if it's for a continuation of the vaccination consult or for a longer vaccination consult or anything related to the vaccination itself. And the normal limits apply, 80-20 rule and general MBS limits apply for the co-claiming arrangements. PIP, so the way the PIP is designed is a sort of an incentive and a recognition that the recall systems and the proactive outreach to patients to come for that second dose has happened. So practices ultimately don't have control for whether people show up for a second dose or not. And there are many cases if the person is traveling that for whatever reason it might not happen, and they can then get it somewhere else because we're trying to have this no wrong door approach so that we maximize coverage. But if that were to happen, then the PIP payment would not be paid in that practice.
Thank you, Lucas. Another question for Charlotte was around, are you expecting vector immunity to the viral vectors, and how might this affect second doses, further doses down the track to boost immunity, or obviously the potential that we might need to provide extra doses given that the virus is changing and we may want to update our immunity to the new versions that are now sweeping around the world. So does the viral vectors that are used, in this case a chimp adenovirus, does that concern you that immunity to the vector will affect the efficacy of future vaccines?
I think at this stage that's not a particular concern as far as I'm aware, and it may become that way in the future, that we do have to address the vaccine specificity. But I think for the time being, it looks very safe at protecting against the current strains.
Yeah, I think the way I heard someone explaining it was that even if you do develop immunity to the vector, it doesn't mean that the virus won't get the DNA into the cell. That may still.
Oh, yeah, sorry, I sort of might have misunderstood what you meant by that. But yeah, certainly immunity to the vector shouldn't have an impact on the vaccine efficacy.
Yeah. Thank you. There was a broad question, which is quite a big one, but I don't know how we get a brief answer. This one's for you, Michael. How do we address vaccine hesitancy?
Well, I think firstly, there's a huge role for all of us to play in tackling vaccine hesitancy. And many of us will be asked by our patients about, should I have the vaccine, to explain. I'm sure many of you have been doing this already. The stats which we've got at the moment show that about 80% of people in Australia are determined to get the vaccine. There is a small group of the so-called anti-vaxxers who, no matter what we do, are probably not going to. And then there's a group of people who are yet to make up their mind. And I think that we as doctors have a huge role to play in providing advice to those people, reassuring them and encouraging them to get vaccinated. The wonderful thing that we've seen over the last 2 weeks in residential aged care facilities, we've had close to 100% of people consenting to get the vaccine, people and their loved ones recognising that this is life-saving, this is incredibly important. And of course, we've had very large numbers of people turning up to get the vaccines in the hubs as well.
Thank you, Michael. We're coming to the end, but I want to squeeze in a couple more questions very quickly. So around 1B, there's been a few questions around how does someone identify as being within 1B? Will it be that they're contacted like 1A, or will they have to self-identify? My guess is it's the latter, but if you could confirm that. And then also there's been a question around what is the list of medical conditions that qualify you under 1B, and how can GPs access that?
So on health.gov.au, there's the vaccine eligibility checker. So people can go on and you can enter your details and it will tell you which group you're in. It includes the list of conditions, which would mean that someone was covered under 1B. So that's probably the first thing to refer your patients to. If your patients don't have access to the internet, you can work through that with them as well. It's pretty clear. The criteria, as we mentioned at the start, may be refined around the edges as we get more evidence about people getting at greater need of the vaccine, but it's there for people to look at right now.
Thank you.
Omar, sorry, if I may add, just as another thing, because we're getting a few comments on the chat. The granular advice on the criteria, because some of the medical eligibility criteria is a little bit broad. Some inflammatory conditions, uncontrolled hypertension, like what do we mean by that, has been finalized. It will be published in the department's website probably in the next few days, but it's already included in the onboarding pack that the GPs are getting as part of the sign up letter. So the GPs that will be delivering the vaccine already have it. More broadly or should have it throughout today. More broadly in the, it will be published in the department's website within a couple of days, and that will have much more clear guidance on the specificity of some of those conditions. And in terms of how do people access it, we think it's going to be a mix. I mean, one of the many beauties of going through primary care is that GPs will be able to proactively identify their patients and call them in for the vaccine.
Thank you. I'm going to answer a couple of quick ones myself. There's a question around what happened to the half dose of Astrazeneca. And I think the answer to that is the thought is it was the longer duration between the doses rather than the half dose that caused the improved efficacy as a result of the trial being suspended for a little while. So that is the answer, and that is what most countries are now doing, going to 3 months between the doses. There was another one I was going to answer. Travel medicine. So a lot of travel medicine clinics, obviously, that they're not eligible for accreditation. They're good vaccination centres. And our understanding is that they will be part of the rollout at some point, and that message has been heard by government. Are you nodding, there, Michael and Lucas?
I'm nodding. We're definitely getting the message, and in fact, I just got the letter from the College of Tropical Medicine, and we are considering the expanded eligibility for many other practices and providers as more doses become available and the rollout continues.
Yep. Very last question in the few seconds we have left is around how we planning at the moment to document vaccination status. Is it still just a certificate? Is there a database that's going to be held centrally, and how's that going to be linked to people's future intentions to travel, etc.?
Not sure if I will, but every dose is entered into the Australian Immunisation Register, which we have access to. If you have a My Health record, it will be recorded there as well. People can also download their vaccination status onto the Medicare app on their mobile phones.
And the providers, it's in the onboarding pack now, the general practices will get, with the delivery of doses, little cards that can be written where the dose has been and when the next appointment is, so that people can take that if they don't have access to their immunisation history status or anything like that.
Now, obviously, this is all linked to the fact that every dose has to be put on the Australian Immunisation Register. That's the key aspect. Everything else stems out from that, obviously, where patients can access that information or provide, written evidence of it.
I know we're over time, but there is just one that I think is quite important from Joanna Kilmartin. How do we document patient adverse reactions without using the blue form currently available on the ADRAC website? Anyone can take it.
So the question about how to report adverse reactions, you have to follow obviously the requirements in your state and territory on reporting, and reporting also goes through to the TGA, which consolidates things for the country.
Okay, thank you, Michael, and hopefully some of that stuff will be in the pack that's gone out as well. Look, we're slightly over time, so I'd like to wrap up at this stage. I apologise for not answering every question that's come through. We will have a look at them afterwards. I think these are somehow recorded, and hopefully be able to get back to any of you who had burning questions that we haven't gotten to along the way, or to publish it more broadly. But I would like to thank our panelists today, Charlotte, Michael, Lucas and Chris, for your time and for your ongoing commitment to health and to this really important rollout. I'd like to thank all our attendees for coming along, for putting your hands up to be part of this on behalf of the nation. And if we need to, we'll be back doing more of these as the rollout continues. Cheers, everybody.
Thank you.